Item number 52 is a hearing of the Board of Supervisors sitting as a committee of the whole to examine the potential consequences of Kaiser Permanente's proposals in collective bargaining with the National Union of Healthcare Workers for San Francisco residents and employees of the city and county of San Francisco who are Kaiser enrollees, for behavioral health clinicians employed by Kaiser, and for standards of behavioral health care professional practice.
Colleagues, we are now sitting as a committee of the whole to examine the potential consequences of Kaiser Permanente's proposals in collective bargaining with the National Union of Healthcare Workers. We have various individuals from NUHW here to present today. Supervisor Chen, this is your hearing, so I'm handing it over to you.
Thank you, Board President. Colleagues, behavioral and mental health care is too important to take for granted. Today, I'm calling a hearing to provide public oversight to the potential consequences of Kaiser's proposals in collective bargaining with the National Union of Healthcare Workers. This negotiation will have an undue impact on city residents and employees of the city and county who are Kaiser enrollees, and for behavioral health clinicians employed by Kaiser. Today's hearing will also consider standards of behavioral health care professional practice. I want to thank my co-sponsors for this hearing, Board President Mandelman and Supervisor Walton and Malga. I originally called for this hearing after hearing from multiple constituents, including Kaiser patients and Kaiser nurses, about proposals made by Kaiser in their bargaining that have the potential to greatly undermine the quality of care that patients are entitled to, create unfair hardship for workers, and undermine healthcare standards that were put in place years ago. I know that representatives from unions will get into this for more in details, but I specifically want to call out that I have heard allegations that Kaiser is using AI or machine learning to replace clinical judgment. I find this absolutely unacceptable. Mental and behavioral health are incredibly complex for patients experiencing them, and even our best and most robust healthcare systems can be extremely difficult to navigate, especially when someone is in crisis. The idea that we would allow AI to provide clinical treatment or triage for patients is shocking, and I have serious concern that without adequate protective language around emerging technologies, we could, at best, make the patient's mental and behavioral health issue more acute or, at worst, inevitably be responsible for driving someone to crisis. I'm not against technology, but without meaningful data, evidence, and clinical validation that emerging technology is ready for the kinds of work that is allegedly being employed through Kaiser, we are rising in putting patients in harm's way. Yesterday, a complaint was filed by NUHW with the California Department of Managed Health Care and the U.S. Department of Labor, alleging that Kaiser's automated e-visit portal for behavioral health makes recommendations without licensed clinicians' review. This is the kind of things that I don't believe AI or machine learning are able to do at this moment. AI and other machine learning emerging technologies are not obligated to patient care or wellness. They do not take a Hippocratic oath. They are not subject to standardized regulations, tests, or oversights. If someone is seeking out their healthcare provider to inquire about behavioral health treatment, and they deserve, at minimum, to be assessed by a licensed clinician on intake. Before we begin, I'm shocked and very disappointed by Kaiser's unwillingness to participate in today's hearing, especially in light of this new complaint. Participation in hearings such as this are an important tool that the board uses to empower the public on key issues of concern. Mental wellness is incredibly important, and how we are taking care of our patients and workers, especially with emerging technology, is more important now than ever. I'm grateful to the members of NUHW, CNA, and other experts are taking time out of their busy day to be here and to educate the public in good faith. With that, I would like to call up Sal Rosselli, President Emeritus, National Union of Healthcare Workers, to kick us off.
Should we have Supervisor Walton, I believe, is in the queue first, though.
Thank you so much,
Yeah.
President Melderman. And I just wanted to add emphasis to Supervisor Chen's statement around Kaiser not showing up this afternoon. I think it is extremely disrespectful that Kaiser is not here, not just for the fact that fair bargaining practices should be basic for an employer, but when this Board of Supervisors makes a request for an employer to attend a hearing, they most certainly should make sure that they are in attendance. So I just want to emphasize how disrespectful that is, that Kaiser has done that, and they need to take note that we know that is disrespectful. Thank you, President Melderman.
Thank you, Supervisor Walton. Supervisor Wong.
Colleagues, as a former hospital union organizer, I believe workers deserve a fair voice at the bargaining table. But this issue goes beyond labor relations. It is also about keeping San Francisco safe, stable, and functioning. Families expect that when a loved one needs behavioral health care, a trained professional will be available before a manageable problem becomes an emergency. When treatment is delayed or interrupted, families are left struggling, and situations that should be handled in a clinician's office can instead end in an emergency room, a 911 call, or a response from police and firefighters. Maintaining an experienced clinical workforce is therefore not simply a union issue. It is practical public safety, responsible management, and better use of our emergency resources. Kaiser serves many San Franciscans, including thousands of city employees. I was born at Kaiser, Gary. I urge Kaiser to bargain in good faith and reach a fair, sustainable agreement that keeps qualified clinicians on the job, protects continuity of care, and addresses behavioral health needs before they become crises. That is good for workers, good for patients, and good for public safety. Thank you.
President Rosselli.
And I'd just like to first thank Supervisor Cheyenne Chen for calling for this hearing. President Melderman, Supervisor Melgar, Supervisor Walton, thank you for co-sponsoring it, and all of you for your ongoing commitment to ensuring that all San Francisco residents and city employees have access to timely, appropriate behavioral health care services. No city has taken stronger action over the years to hold Kaiser Permanente accountable for its repeated mental health access and parity violations, and to support clinicians in their fight for the time, resources, and respect that they need to best serve the people of San Francisco. This hearing comes at a pivotal moment, as reported in today's San Francisco Standard, when Kaiser is proposing to exploit new technology to save money and avoid accountability, rather than finally providing the behavioral health care that patients need and that they, their employers, and San Francisco taxpayers are paying for them to receive. Our members stand ready to work constructively with KP management to make Kaiser the best place to give and receive behavioral health care. I still believe there's a lot we can accomplish together, but we'll never make progress as long as Kaiser's intent on trying to silence us and replace us. Thank you again for holding this hearing and for your commitment to achieve real mental health parity, real behavioral health care parity. NUHW's Legislative Public Policy Director is going to speak next, Benjamin Eichert.
Good afternoon, President, supervisors, and members of the public. My name is Benjamin Eichert. I'm the Policy Director for the National Union of Healthcare Workers, representing the 2,400 psychologists, licensed clinical social workers, marriage and family therapists, and other behavioral health professionals who care for Kaiser Permanente patients throughout Northern California. Thank you for holding this hearing. This is not the first time we've been here. In 2022, this board held a similar hearing in the midst of a 10-week strike, during which Kaiser was found to have canceled more than 100,000 therapy appointments region-wide. That strike itself came after multiple prior strikes going back more than a decade and multiple rounds of state sanctions against Kaiser's behavioral health services dating all the way back to 2013, which included the imposition of an outside monitor for 3 years. With your support in 2022, NUHW clinicians won more time for patient care duties that can't be done during appointments, like responding to patient calls and tailoring treatment plans. They also won a voice in the model of care. So after nearly 2 decades of deficiencies and labor strife, it seemed like Kaiser was ready to begin repairing its relationship with behavioral health clinicians. Unfortunately, it ended almost as quickly as it began. Since we settled that contract in 2022, Kaiser has been assessed $231 million in state and federal penalties as part of 2 separate investigations. In a 2023 settlement with the California Department of Managed Healthcare, which included a $50 million fine, Kaiser acknowledged that it lacks sufficient behavioral health providers and that, quote, this lack of clinical staff has resulted in excessive wait times for enrollee individual therapy appointments. 3 years later, the Department of Labor ordered Kaiser to reimburse patients more than $28 million for out-of-pocket mental health care costs incurred because Kaiser didn't provide them the services that they paid for and were entitled to receive. These penalties may seem severe, but for Kaiser, they're a drop in the bucket. Last year, Kaiser reported profits of $9.3 billion, and by year's end, it held nearly $73 billion in reserves of cash and investments. Yet despite these massive financial resources, Kaiser executives backtracked on their commitment to work with clinicians to improve behavioral health care. The 2022 contract included labor management model of care committees that made recommendations on improving care. Now, Kaiser has stopped funding the recommendations of those committees, which they had contractually committed to do. At the very same time that Kaiser entered into its $200 million settlement agreement with state officials, it started using questionnaires and scoring algorithms administered by call center operators and online tools rather than licensed behavioral health clinicians to screen patients who are seeking therapy for the first time. Human engagement and judgment have been removed from this critical point in the process of intake and assessment and initially assigning patients to a care pathway. Despite all this, NUHW clinicians are simply seeking a contract with Kaiser that reaffirms the improvements we've begun together to make things better for patients. Unfortunately, since negotiations started over a year ago, Kaiser proposed reversing the most important gains therapists have made. Kaiser has also proposed what clinicians are calling the terrible 3. These 3 extreme demands would degrade the standard of care for patients and set a dangerous course for the future of behavioral health services throughout the region and the state, a course that other insurers and providers will likely emulate to try to save money. The first demand involves artificial intelligence. In its Southern California contract with NUHW members signed last year, Kaiser agreed that the use of new technologies, including AI, quote, is not to replace, but to assist bargaining unit employees in providing safe, therapeutic, and effective patient care and support. But now, Kaiser is refusing to agree to that language in Northern California, just as it has begun replacing therapists with technology to triage patients seeking care. To mask its intentions, Kaiser is promoting an AI committee, but the committee would have no power at all. Kaiser could veto the union's appointments to it and ignore the committee's recommendations. Their second demand makes a mockery of Kaiser's stated commitment to an integrated model of care where therapists can work closely with doctors and other caregivers under a unified clinical management structure. Instead, Kaiser is proposing to eliminate contract language committing that the use of subcontracted therapists, quote, will not result in the elimination, end quote, of employed clinicians. They've even proposed the details of severance packages for clinicians who would be laid off. This would give Kaiser a green light to subcontract an even larger volume of behavioral health services to independent providers performing gig work on mental health platforms. These therapists can't easily communicate with the rest of Kaiser's care team, leaving behavioral health care as a separate and inferior service segregated from the promise of Kaiser's integrated healthcare system. Kaiser's proposal wouldn't just degrade care for Kaiser patients, it would degrade pay and benefit standards for clinicians, including those outside of Kaiser who have no voice through a union and work at the mercy of insurers, employers, and platforms whose only goal is to keep clinician reimbursements as low as possible to maximize their own profits. The third provision would hand Kaiser total control to determine how care is provided. For the first time, Kaiser is demanding a provision in the contract stating that Kaiser has the sole discretion to, quote, determine or modify the behavioral health operating and clinical models of care. This would force therapists to surrender the clinical autonomy they need to do their jobs in compliance with professional standards and state law, and it would invite other major insurers and employers to demand the same of their clinicians. Kaiser's stated excuse for making this demand is that mental health professionals in Southern California agreed to it last year. But what Kaiser doesn't say is that it proposed that provision deep into a nearly 7-month strike, and that workers very reluctantly agreed to it as part of a painful compromise to end that bitter struggle. Kaiser's terrible 3 demands show that instead of working with clinicians to improve care, Kaiser wants to silence clinicians and avoid accountability. And the proposals Kaiser is making at the bargaining table have consequences that extend far beyond one employer. If Kaiser succeeds in silencing its clinicians while moving full steam ahead to outsource care and push patients onto AI platforms, other insurers and employers will have every incentive to pursue similar changes. That would degrade the quality of behavioral health care in San Francisco and across California. The Board of Supervisors has consistently stood for equitable access to care, strong public health systems, and responsible corporate conduct. Opposing Kaiser's terrible 3 proposals is consistent with your values. It would send a clear message that San Francisco expects its largest private insurer to strengthen and not weaken behavioral health care. It would tell Kaiser that innovation should support clinicians rather than replace them, and that integrated care should be more than a marketing strategy. Most importantly, it would tell thousands of Kaiser patients that their city stands with them and those who provide their care to demand accountability from their powerful and well-endowed HMO. Thank you for your time, your leadership, and your commitment to protecting access to quality mental health care for the people of San Francisco and throughout California. Next, you're going to hear from 3 therapists at Kaiser who are members of NUHW: Alana Marcucci Morris, Molly Parsons, and Tiana Loy.
Good afternoon. My name is Alana Marcucci Morris, and I am a licensed clinical social worker and therapist at Kaiser Permanente in Oakland Adult Psychiatry. I also serve on my union's bargaining committee. For most of my 7 years at Kaiser, I worked as a triage clinician. When someone called seeking mental health or addiction medicine services, whether they lived in San Francisco or Stockton, the first person at Kaiser they talked to would be someone like me, a licensed human therapist with specialized training to assess their condition and their treatment needs. A triage screening is about determining risk and how urgent someone's treatment needs are. Is this person a threat to themselves or their loved ones? Or can they wait 10 days for an intake appointment? Do they need immediate intervention or a wellness check? We make these determinations using our clinical judgment and our own humanity. We ask follow-up questions. We listen to not only what they say, but what they don't say, or how they say it. We observe their tone, their consistency, and listen for cues that indicate higher risk or warrant immediate intervention. This is the accepted standard for how triage should work in mental health care, but it's now the exception and no longer the norm at Kaiser. Instead of being able to count on human licensed therapists to assess and decide the best first steps for their treatment, relying on our extensive training, professional judgment, and many years of experience conducting risk assessments, Kaiser patients reaching out for our services now rely on the initial phase of their care being decided by questionnaires that are either read by telephone operators or self-administered online. Their answers are fed into algorithms that instantly decide if a patient qualifies for therapy, a class, an online coaching program, or no care at all. We have filed complaints against this practice, which started in 2023. Kaiser has refused to confirm whether the digital algorithms are generated by artificial intelligence, but their use clearly violates California law requiring triage assessments to be provided by a, quote, physician, registered nurse, or other qualified health professional acting within their scope of practice and who is trained to screen or triage an enrollee who may need care, end quote. Kaiser isn't just violating the law by having new technology do the work of its human clinicians, it's violating patient care standards and putting patients at risk. Artificial intelligence and algorithms don't capture what trained humans can. A common symptom of depression, for example, is to minimize your symptoms. When making determinations based exclusively on patient reporting, an algorithm may deem a patient with a more severe condition as only having a mild or less significant symptoms. I see this all the time since Kaiser started using telephone operators and algorithms to screen patients seeking care. So as that work was reduced, my current job, what I do more of these days, is predominantly conducting scheduled intake assessments with people after they've been, quote, triaged by an unlicensed operator or an e-visit on the Kaiser app, typically around 2 weeks later. The acuity and critical nature of symptoms I am seeing has increased significantly because the app, AI, an algorithm, or an unlicensed telephone operator incorrectly determined that they could wait 10 days to see me. Or they perhaps waited even longer because they were inappropriately booked elsewhere, and now I have to fix their care plan. I have watched patients withdraw from substances on camera because nobody told them to go to the ER or consult a physician sooner. Apologizing to patients during an inappropriately booked intake appointment because they expected to be seen by a psychiatrist capable of refilling their critical medication has become a routine part of my days. As a member of our union's bargaining team, I didn't think new technologies like artificial intelligence and algorithms were going to be a major issue in our negotiations. Last year, our counterparts who provide behavioral health care for Kaiser in Southern California settled a contract with language stating the intention of new technologies was to support therapists, not replace us. So we were stunned when Kaiser rejected that exact language for us here in Northern California. We asked their bargaining team flat out if that meant they were planning to replace us, and they said that they wanted that flexibility. I believe Kaiser can't promise not to replace us with AI in our contract because it is already doing it. It is already using new technology to take work away from us human licensed therapists, and it wants to be able to replace us altogether. Kaiser has never truly understood mental health care. The relationship between the therapist and the patient is an integral part of our treatment. Our patients aren't coming to us with broken bones. You can't fix depression with a screw and a nail. This is inherently human work, and we have to use our humanity. I use my human empathy to help patients heal, and I use my human anxiety to keep my patients alive. When my anxiety goes off, my internal meter that this patient needs a little bit more of my attention to stay safe, that gives me the chance to lean into their care when those risk factors pile up. As a human, I am also accountable. I can lose my license if I commit malpractice. Will software developers or billion-dollar health plans be held accountable when technology makes a fatal error? I do not see AI being used for good where I work. I see it making dangerous patient care errors. I see it reinforcing racial and gender bias. Yet Kaiser is proposing to increase its ability to lay off therapists and outsource more patients to third-party companies that use chatbot coaching, chat-based therapy, and other innovative behavioral health apps in order to reduce its need for human labor. This isn't about genuine innovation. It's about saving a buck at the expense of patient care and public health. If we don't stop them now, we won't stand a chance down the road. Thank you.
Hello, everybody. My name is Molly Parsons. I am a therapist at Kaiser, and I have been for 5 years. But I also have a private practice where I work with an agency or a third-party contractor and non-Kaiser patients. So my agency that I work for is similar to those that Kaiser wants to outsource care to for as many mental health, behavioral health patients as it chooses, even if that means laying off staff therapists like myself. Now, if you've ever seen a Kaiser advertisement, and they're hard to avoid, you know that Kaiser touts its integrated healthcare system. All of your providers are under one roof, communicating and coordinating care for you seamlessly. And in fairness, that model, that integrated healthcare system, is an excellent model. That's why I can't really understand why Kaiser wants to segregate behavioral health from it and treat it as a second-class service. Within Kaiser, I communicate with other care providers to let them know about what is going on with a mutual patient, to nudge them when they've dropped the ball, or vice versa, frankly, and to advocate for the needs of clients. I can see what is physically impacting patients if they've been hospitalized or admitted to the ER, and any test results. I can see what appointments they've attended or those that they've missed, and knowing all of this information helps me provide better resources for each client and helps me better prepare for each session. The opposite is true when I'm seeing patients through third-party contractors. When I open their charts, I don't see any notes from their physicians. I don't know what is happening with them physically or medically. Typically, clients use these third-party contractors for therapy only, and they even get psychiatrist care elsewhere. If I have concerns about physical or medical issues, it's difficult to connect with the other care providers, and so often there isn't any consultation. Outside therapists cannot even prescribe time off work or give accommodations if those are needed. So there's something else to understand about referring people outside of Kaiser. Nearly all of the appointments with Kaiser's third-party behavioral health contractors are telehealth. And that doesn't work for a lot of people, like older adults, younger kids, and those who don't have a safe space to take a call from. These issues are part of the reason many Kaiser patients who have been referred to a third-party contractor end up returning to Kaiser. People's conditions often get worse when they've bounced back and forth between Kaiser and external providers. The shuffling among multiple clinicians inhibits the therapeutic alliance and disrupts the continuity of care. What's more, when they return to Kaiser from outside treatment, it's harder for us to meet their needs because our schedules are so full, we can't see them as quickly as they need to be seen, and we can't give them the frequency that they need. They are stuck then choosing between more frequent therapy with an external provider without the integrated model they signed up for and pay for, or to be seen less frequently than they need. One of the most frustrating aspects of the third-party contractors is they see the easy clients with mild issues, those that likely could be seen less frequently. But they are the people who they are the people who can actually see clients weekly, the third-party contractors are. Kaiser keeps all the severe and high-needs clients to, quote-unquote, monitor them. But tell me, how can I monitor my high-needs clients when I don't have any open appointments? One of the deficiencies Kaiser was cited for as part of the $200 million state settlement agreement was not adequately monitoring its external provider networks. I've been seen as a client myself through these external provider networks, and I can attest to my negative experience. I've had a therapist not show up multiple times, not focus on the issues that I've raised. I've asked for specific types of therapy and been assigned to therapists, and when I meet them, they don't provide that at all. Now, Kaiser wants to be able to rely on external provider networks entirely and lay off its staff therapists. Kaiser's hypocrisy is maddening. In public, it says, join us, and you'll get the benefits of integrated healthcare. But in private contract negotiations, Kaiser tells us that mental health isn't important enough to remain part of its integrated healthcare system. Look at the big picture. Kaiser has $73 billion in reserves, and it has racked up $231 million in penalties for mental health violations over the past 3 years alone. Yet one of the main reasons we don't have a contract over a year of negotiations is that Kaiser is insisting on being able to provide a lesser standard of care to behavioral health patients. And the changes it wants to make completely contradict how Kaiser markets itself to the patients we serve. Make it make sense to me. What Kaiser is proposing wouldn't just be bad for Kaiser patients, it would be bad for behavioral health care in San Francisco and California. Kaiser's proposal would further encourage other HMOs and provider groups to treat behavioral health as a separate and therefore lesser service, and follow Kaiser in taking steps to lower their costs and replace human care with technology. At a moment when insurers are already cutting reimbursement rates for mental health therapy, Kaiser's proposal would drive even more California therapists to forego insurance and only see patients who can pay out of pocket. Kaiser clearly wants to radically downsize its behavioral health workforce and rely more on apps and external vendors. We want Kaiser to provide good care and good jobs, just like their ads say they will. Thank you.
Before the next speaker, I would like to tell members of the public there is a prohibition on audible sounds of support or opposition outside of our commendation period. So if you would like to show your support, please use your hands. Thank you.
Hi, my name is Tiana Loy, and I'm a therapist for Kaiser here in San Francisco. I started late last year to be part of a new LGBTQ plus treatment track. Last month, I told management that I was leaving Kaiser because the track had not yet materialized, and I wasn't treating the people I knew that I could best serve. But I'm still here because, to my shock, management responded by finally getting the LGBTQ plus track up and running. I'm giving it a shot, but there are still really big problems. So to start, we don't have enough staff or clinical autonomy to do our best for patients, and there's absolutely no excuse for this. Instead of seeing people every 2 weeks as required by state law, my patients, on average, if they're lucky, have to wait 3 to 4 weeks between appointments. There have been times when a client has reached out to me saying, "I've had a loved one pass away. Do you have an appointment? Can I be seen sooner?" And I have to say no. Other times, I've had last-minute intake appointments with patients who are higher risk and need to be seen weekly, but I can't see them for 3 weeks because I don't have any appointments. Kaiser's model of care flat out does not work. It often takes patients a month between when they are first screened for treatment and when they actually start treatment with their Kaiser therapist. By the time they come to us, their symptoms are often worse, and they're upset over how they've been treated and that they're going to have to wait another few weeks to be seen again, and so the cycle continues. The screening process itself has been degraded. Now that Kaiser uses telephone operators and AI algorithms to screen patients, there is no method for them to request preferences in a therapist that may influence treatment, such as cultural background or gender identity. I've had LGBTQ plus patients tell me they've waited forever to find a clinician with my background, and that they were going to forego treatment if they did not come to someone like me. When patients are essentially told, "Here is your option, take it or leave it," that is not ethical, and that is not good clinical care, not at all. Kaiser's model doesn't just shortchange patients on their way into the system. There's a term we have called Kaiserize. So Kaiser takes evidence-based treatments and offers patients less than a clinical standard. So for example, a 90-minute session becomes a 60-minute session at Kaiser. A program that requires 12 sessions to graduate becomes an 8-session program at Kaiser. Kaiser's model is to keep putting less Cheerios in the box and hope that no one notices. Denying us a voice in the model of care would help Kaiser ensure no one ever notices. Kaiser's approach to behavioral health care boils down to this: keep staffing low and make everyone do nonstop work. In previous jobs I've held, I'd have about 20 to 25 clients per week. But at Kaiser, I'm expected to see 31 patients per week. There is almost never enough time for chart review, preparation, clinical documentation, and follow-up care coordination and consultations. If I have a cancellation on my schedule, I have time to pee and drink water if I'm lucky, but then typically I'm immediately booked at the last minute, usually with a high acuity patient, and almost never enough time to review their charts. Kaiser wants maximum productivity, but we're not making widgets. We're helping people confront devastating trauma and discuss their most private thoughts. We need to be 100% present. But is my last patient of the day getting as much as me as my first patient? My only hope in trying to stay with Kaiser is that we're bargaining for a new contract and that we can make things better. But Kaiser wants to make things worse. They want to be able to book patients into the precious hour or so of protected time I get every day to prepare for appointments, and then frantically respond to patient calls and emails, finish making notes in patient charts, and call social service agencies. If Kaiser prevails in contract negotiations, I won't be able to do this job anymore. There would be no break whatsoever just to breathe. It would be physically, mentally, and emotionally impossible to do the job because we're already stretched so thin. It's one thing to work frantically, knowing that your work is making a difference, But it's intolerable when you know that as fast and as hard as you work, it's not enough for the people who depend on you. When I see patients only once a month, it's hard to build rapport. It feels like each time you meet, you're starting over. It's terrible for patients. They get frustrated. Sometimes they get into crisis and need a higher level of care. We all know that Kaiser has a problem when it comes to behavioral health care. The question is, how do we solve it? Kaiser thinks that only management control can fix the problem, but they don't know what the real problem is. They think the problem is that they're getting fined and penalized, and the solution is to silence those of us who blow the whistle on them. So for clinicians like me, the goal is not to help Kaiser stay out of trouble with state and federal regulators. Our goal is to help our patients to the best of our ability. We can't do that if we have no say in Kaiser's model of care. Do you really trust that Kaiser management alone can fix this problem? Because after a year at Kaiser, I certainly don't. Thank you.
Thank you, all the presenters. Before we go to questions, let's call up all the presentations. Can we have Dr. Jasmine Smith, Associate Executive Director of the National Association of Social Workers, California chapters, up? And then after Dr. Smith, let's have Dr. Linda Michaels, Chair of the Psychotherapy Action Network. Dr. Smith.
Good afternoon, President, Chair, and Supervisors. Thank you for the opportunity to join the discussion today. My name is Dr. Jasmine Smith. I'm a Doctor of Social Work and licensed clinical social worker and the Associate Executive Director of the National Association of Social Workers California chapter, where I lead statewide professional development, policy advocacy, and legislative initiatives that strengthen behavioral health workforce and represent more than 9,000 professional and student social workers supporting vulnerable communities. Social workers are guided by the NASW Code of Ethics, grounded in the principles of service, social justice, dignity and worth of the person, the importance of human relationships, integrity, and competence. They are ethical obligations that guide every clinical decision we make and every relationship that we build with those we serve. Additionally, as registered associates and licensed professionals, we are also held accountable to the California Board of Behavioral Sciences to provide competent, appropriate care consistent with our ethical and legal responsibilities. However, many of our members employed by Kaiser have reported that they felt systemic barriers directly impacted their ability to adhere to the Code of Ethics. First, behavioral health screenings are typically a client's first interaction in seeking mental health care, and it is crucial that they are met with an ethically and culturally competent provider who can not only provide the empathy and warmth required to authentically build rapport, but aid the client in sharing their concerns and symptoms. The licensed clinician conducting the assessment has the expertise and knowledge to recognize the subtle signs of crisis, trauma, or escalating risk that may not be obvious in a scripted conversation. It is deeply concerning to learn that Kaiser Permanente has replaced licensed behavioral health professionals with unlicensed staff and algorithmically directed screening tools during the initial intake process since January 2024. The call center operators who apply these tools are not qualified to recognize risk factors, exercise professional judgment, and determine the appropriate level and urgency of care. Additionally, Kaiser has refused to answer whether its screening tools rely in any way on artificial intelligence. AI can only reflect the data that it is trained on, and we know that healthcare data reflects longstanding inequities. Researchers, including Dr. Tiara Tanksley, has recently highlighted how AI can reinforce existing disparities when historical bias is built into the data used to develop these tools. A 2022 study found that a machine learning system algorithm caused Black patients to experience 33% longer wait times because it relied on factors that were closely tied to race. And more recently, in 2024, a systemic review found that racial disparities in healthcare AI are driven by biased data sets, historical inequities, algorithm design, and the way these systems are implemented. Kaiser Permanente plans to expand the use of AI algorithms in behavioral health screening and treatment. But when they are doing that, these studies cannot be ignored. Decisions about how quickly someone receives treatment or what level of care they need should not be influenced by technology that reinforce these existing disparities. AI can be a helpful tool to support administrative tasks or assist clinicians, but it should never replace the professional judgment of licensed behavioral health providers, especially when patients are seeking help during moments of crisis. Kaiser's actions put it out of compliance with the California's requirement under the Health and Safety Code Section 1367.03, which directs that behavioral health services must be assessed and referred by licensed behavioral health providers. These behavioral health assessments simply cannot be reduced to scripted questions or algorithms because they set the foundation for treatment, and getting them wrong can have serious consequences for patient safety. While Kaiser may claim that there are benefits from this change, since January of 2025, therapists have documented more than 70 examples of negative patient care outcomes associated with these new screening processes, such that patients determined to be high risk experience longer wait times of more than 1 week to initiate services, again, jeopardizing their safety. I would also like to address the concern of provider burnout in relation to client care. A 2025 study found that high levels of burnout among mental health professionals often cause them to lead to increased staff turnover, causing a ripple effect in which remaining staff members take on heavier caseloads, leading to further burnout and exacerbating the cycle of staff departures. This creates an unhealthy environment in which insufficient resources are there to meet patient needs, causing the providers to have less time to dedicate to each patient, less individualized patient care, and in addition to the reduced time for patient interactions, burnout has been associated with decreased productivity and lower quality of work. But most importantly, it undermines the therapeutic relationship as it impacts the client's attunement with their clients and ability to engage with empathy. We have also heard from our members as they have shared the overwhelming burden of not only having enough time to decompress and process between patients. One noted that they have made multiple errors with clients as they cannot be entirely present due to their work overload. Another noted that they see 6 to 8 clients a day and end up working an additional unpaid 3 hours after a scheduled 8-hour day every single day of their shift, just to ensure that they're meeting their productivity quotas in fear of termination or retaliation. Lastly, one shared that they cannot feasibly provide clients the care they need outside of their appointment time because they struggle with the reality that their clients may not be seen for another month, as their schedule is constantly filled regardless of the appropriate or acuity of the symptoms. While increasing appointment values may appear efficient, reducing protected time for patient care support outside of appointments limits clinicians' ability to provide thoughtful, coordinated, and comprehensive care. Finally, we are deeply concerned about Kaiser Permanente's increasing reliance on subcontracted behavioral health providers through digital platforms such as Growth Therapy, Headway, NOCD, Open Mind, Rula, Sounder Mind, and Uplift. Our members have shared that when a patient's regular clinician is temporarily unavailable, they are often redirected to an outside provider instead of returning to their established therapist. These disruptions can make it harder for patients to maintain consistent care and rebuild trust with a new provider, which is especially challenging in behavioral health, where the therapeutic relationship is central to treatment. This is especially concerning as Kaiser has long promoted an integrated model of care where behavioral health providers work together across disciplines to support patients. However, our social workers have shared concerns that their experience, recommendations, and clinical perspectives are not being meaningfully considered when decisions are made about how care is delivered. They describe situations where they are directed to follow workflows, treatment timelines, referral processes that do not align with their professional judgment, including pressure to end treatment before patients were ready, keep patients in programs that did not fully meet their needs, or delay referrals for higher level of care even when needed. These experiences highlight why it is important that social workers have a meaningful voice in shaping the systems and policies that directly impact patient care. Patients deserve timely access to licensed clinicians, and providers deserve the time necessary to deliver ethical and effective care. And technology should enhance healthcare rather than replace the expertise and human connection. For all these reasons, the NASW California urges Kaiser Permanente to withdraw its Terrible 3 contract proposals and realign their practices with ethical care by investing in licensed behavioral health professionals, preserving integrated care, protecting clinicians' ability to provide quality care, and ensuring that technology is implemented in ways that advance equity rather than deepening existing disparities. We ask that you join us in this call upon Kaiser, and we thank you for your time.
View where the notes are on the side. Okay, great. Thank you. Thank you very much for your interest in these issues. I'm here to talk about them from the standpoint of the evidence base of how and why psychotherapy works, and to share some research findings that are relevant to the Kaiser proposal. Okay, there we go. I'm a licensed clinical psychologist. I'm in private practice in Chicago. I'm also the chair and co-founder of Psychotherapy Action Network, a nonprofit that advocates for the public's access to care and also for clinicians and the clinical standards needed to provide that care. We conduct a lot of our own research. We've produced a lot of publications, from white papers to articles to a book, Advancing Psychotherapy for the Next Generation. And founded in 2017, we've grown substantially since then. I'm sorry, which? Okay. Okay, gotcha, thanks. Okay, so what makes psychotherapy effective? It's the relationship. You've heard a lot about the alliance between the therapist and the patient. This has been studied for decades in many different forms of research, and the same conclusion is reached time and time again. This means the therapist must be able to assess, build, maintain, and adapt that alliance with each individual patient over time. When you mess with the alliance, you mess with what makes therapy work, and you mess with what makes therapy therapy. Effective treatments must also be individualized, not standardized, for each patient, and they must be of sufficient depth and duration to ensure recovery. Each person is unique in terms of many factors: their diagnosis, their complexity, their personality, coexisting issues, trauma history, resources, identities, and more, and the care must be individualized to them. Helping people with issues like trauma, addiction, abuse, relationship stressors, it doesn't work like an antibiotic does, where it's the same treatment for everybody. When it comes to mental health, different people need different approaches and different models of care. Evidence-based standards of care show this as well. We have to treat underlying and chronic conditions. And when we talk about depth, we're talking about getting underneath those superficial symptoms And when we talk about durations, we're talking about, for many people, 40, 50, or 75 sessions of care. This is the standard of care. So, Kaiser's first proposal is to have sole discretion over the model of care. This directly interferes with what we've just discussed about how and why therapy works. This is messing with the alliance. Mandating a single standardized model of care contradicts the evidence base and the importance of the therapist to assess, treat, and adapt to each patient individually. One size fits all works for no one. With this proposal, I would predict that outcomes will worsen and people will not feel helped or understood, and they will drop out of care. Secondly, Kaiser wants flexibility over substituting the work of licensed clinicians with AI and a refusal to maintain the language they agreed to in Southern California. This is very serious. This won't bode well for mental health outcomes either. It's really best to think of AI mental health tools as self-help. That's where they are today. They're self-help interactive guides, interactive journals. They are not an equivalent, let alone a replacement for psychotherapy by any means. So using more AI means giving people self-help tools. The safety risks are very high. I'm sure you have all heard in the press tragic cases of people dying by following the instructions of AI chatbots and the biases and stigmatized information that's inherent in the large language models. No long-term studies exist to show whether AI-enabled treatments even work. And several states, including mine, Illinois, have already restricted AI for these reasons to a support role only, which is where I think it needs to be, and these tools also need to be regulated by the government, by the FDA, just like any other medical intervention. I'm not going to go through all of these, but I just want to show this slide, the risks of trying to replace psychotherapy with AI. The list is long, and there's a lot of serious items on this list. As far as outsourcing without restriction, Kaiser wants the flexibility to outsource psychotherapy to outside providers, which is very concerning in terms of that therapeutic alliance, as well as clinician autonomy and job satisfaction. Sending patients to other clinicians directly severs the alliance. This will compromise treatment outcomes, dissatisfy patients, dissatisfy therapists, and increase patient dropout rates. This is messing with the alliance. While this may save Kaiser money in the short term, it's a very costly long-term strategy. When people get effective psychotherapy, they actually have fewer ER crises and ER visits, lower hospitalizations, and actually lower overall medical spending. They take better care of their mental and physical health. The entities that Kaiser wants to outsource to are particularly problematic. There's already research and studies out there showing that these platforms have significant problems in a variety of areas, from treatment efficacy to therapist satisfaction and confidence in the platforms, patient privacy, transparency, and more. Here's a bit more detail on these problems. This is from a research study that we conducted and published last year on these platforms. Privacy problems. These companies don't adequately protect patient information. This is the foundation of care. Their investors are big tech firms, and they outsource to AI companies, and there's a lot of data sharing and AI training going on. Lack of transparency regarding really basic things, such as who owns these companies, who are the major investors, how are therapists even paid? These are questions that therapists who use these platforms currently do not know the answer to. And there are a series of policies that many of these platforms have which really are adding up to trying to replace actual psychotherapy with mere crisis management. Regarding Kaiser's desire to no longer protect the full meaning of clinical care. Clinical time includes not just the face-to-face meeting with the patient. There's a lot of consultation, collaboration, and coordination with other therapists. If you're seeing a couple or a family, you have to interact with the other therapist seeing the other part of the couple, the parents, the kids, psychiatrists. There may be medical doctors involved if there are serious medical issues going on. These tasks are just part of care, and they take time. If new intakes are scheduled into this block of time, this is actually quite bad for those new patients because they're unlikely to be seen again anytime soon, and it's also not good for Kaiser. They will be creating a system that just gives an illusion of access without any real meaningful access to care. For therapists, having basic autonomy over their own schedule is a documented protective factor against burnout. Burnout is a direct precursor of turnover, and turnover, as you know, would be exceedingly expensive for Kaiser. It's also really costly for patients. When their therapist leaves, most of them drop out of treatment altogether. Kaiser's proposals taken together will undermine the very factors that make psychotherapy effective and even possible, and there will be negative results and high costs to clinicians, to patients, and even to Kaiser itself. I strongly urge the board to reject the Kaiser proposals and support clinicians and the Therapeutic Alliance and what we know makes for effective care. If you said we're going to assess and diagnose by a robot and then give the same treatment to everyone, regardless of how they respond to it over time, and mess with the very thing that makes therapy effective, you know this sounds like a terrible idea. So please, I urge you to stand up for the principles of effective evidence-based care and what we know as far as what works for clinicians and patients. Thank you very much.
Thank you, Dr. Michaels. And let's have our last presenter, Sydney Simpson, registered nurse, Kaiser San Francisco, member of CNA.
Good evening, supervisors. My name is Sydney Simpson. I'm a member of the California Nurses Association. I work as a registered nurse at Kaiser San Francisco in interventional radiology. My siblings from NUHW have highlighted the dangers of unregulated AI in our healthcare system. I just want to kind of build on that and talk about it from our perspective, the nurse perspective, and how it all sort of fits together into a really dangerous pattern of decisions being made by Kaiser that blatantly prioritizes profits over patient safety and quality of care. Since the Trump inauguration last year, we've seen Kaiser take an increasingly hostile approach towards their unionized nurses. Kaiser has committed large-scale wage theft against nurses and is refusing to remit owed retroactive payments. Kaiser in San Francisco and beyond is cutting many vacant RN and nurse practitioner positions, leaving our departments dangerously understaffed. Here in San Francisco, Kaiser has administered cuts to RN staffing in primary care and the emergency department, which of course are the main departments by which patients access care. These cuts have resulted in increased delays in care. I've personally seen Kaiser patients, including my own coworkers, struggle to access medically necessary care and actually leave the city or even the state to access that care. While Kaiser has fully launched its new virtual sitter program in which a remote monitored iPad is responsible for preventing patient falls on the inpatient side, the Kaiser San Francisco Emergency Department has seen a truly shocking increase in patient falls. Nurses have submitted petitions and written letters to Kaiser administrators requesting plans of corrective action to address the cuts to staffing and the subsequent impacts to patient safety. Kaiser refuses to disclose this information. Additionally, Kaiser's vast investments in untested AI signals an effort to divert funding from in-person caregivers to new, untested technologies. Nurses are not against scientific or technological advancement, but we will not accept algorithms replacing expertise, experience, holistic, and hands-on approaches that we bring to patient care. If it's what you would demand for your family, then that is all we are demanding for all of our patients. Kaiser's using algorithmic systems to quantify nursing workloads and patient acuity levels, which includes shift staffing decisions, RN to patient assignments. This often results in inappropriate nurse-to-patient ratios and unpredictable scheduling. Instead, patient acuity measurement should be based on an RN's clinical judgment and a hands-on assessment. Kaiser's also implemented a technology that they ironically call the CAST system. And yes, that is really the name of this technology. The tech scans a patient's chart and determines how much time the patient will receive for their pre-surgical screening appointment and whether they will have access to a doctor or a nurse practitioner. We have asked Kaiser repeatedly what specific information the CAST system robot uses to determine and ration that care. Kaiser refuses to disclose this information. CNA-represented nurse practitioners discovered that language translation needs of a patient are not factored into the appointment time of the CAST system. This is fundamentally discriminatory, as translation obviously takes time. Without increasing the length of appointment times for patients with translation needs, Kaiser therefore is providing such patients with less time in their pre-surgical screening appointments than that afforded to patients without translation needs. Kaiser has also accelerated the outsourcing of our patients' care to third-party facilities and entities that do not have the same oversight and union protections. Kaiser's pushing acute care patients out of the hospital and into the home through their Advanced Care at Home initiative. This program places cameras in the homes of acute care patients and replaces 24-hour nursing care with 24-hour surveillance. Kaiser has contracted non-union nurses to surveil these patients from remote and undisclosed locations. Kaiser is relieved of the obligation of cleaning, caring for, and comforting these patients, and this labor now falls solely onto the patient's family members. Our nurses are reporting that many of the patients placed in the Advanced Care at Home program, we call this Care All Alone instead of Advanced Care at Home. Our nurses are reporting that many of the patients placed in the Advanced Care at Home program are being readmitted to the hospital due to premature discharge and fractured continuity of care. In San Francisco, many surgical patients under Kaiser are sent to the SF Surgery Center, which is adorned with Kaiser Permanente signage, but it is in fact a distinct and very separate entity from Kaiser, and the nurses working there have no union protections. Nurses have requested information on the policies and procedures, the infection control protocols, and the patient inclusion and exclusion criteria for the SF Surgery Center. Kaiser refuses to disclose this information. CNA has received reports from nurses working at the SF Surgery Center that without union protection, they're fearful to speak up and advocate for patient safety. With their multi-billion-dollar profits, Kaiser could easily expand staffing to extend the hours of both inpatient and outpatient operating rooms to meet the surgical needs of our patients. But Kaiser has refused such proposals and continues to contract out care and operations. So in closing, we call on Kaiser to do better and turn their rhetorical claims into action. With so many city workers and SF residents dependent on Kaiser's care, we appreciate this board working to ensure that the millions of dollars of public funds that are remitted to Kaiser annually are being spent back into the care of city workers and SF residents. Kaiser can demonstrate their commitment to improving patient care by 1, replace vacated positions, 2, increase staffing and patient care capacities, 3, insource outsourced work, and 4, provide transparency and oversight of all new technologies. Our experience of Kaiser's increasingly blatant disregard for accepted standards of care, its inappropriate deployment of AI and other tech in place of human health care professionals, and its growing aggression towards its unionized workforce is parallel to that experienced by NUHW members. CNA shares NUHW's assessment of the negative effect of Kaiser's terrible 3 bargaining demands, and we join NUHW in calling on Kaiser to withdraw them. We ask that SF Board of Supervisors support both unions in protecting patients from these attacks. Nurses know that Kaiser can serve our city better and stop using the city and county of San Francisco as a means to collect revenue for their private investment strategies. Rather, they need to invest their multi-billion-dollar profits, much of it collected here in San Francisco, back into the care of our communities. Thank you.
Thank you, Sydney. Now let's go to questions. My first round of questions will go to Mr. Eichert. Would you come back to the podium, please? Mr. Eichert, Kaiser has long been known as a labor-friendly healthcare employer, and towards its history of labor management partnership. When and how did this go wrong in the specific case of behavioral healthcare? Most recently, how can it be that the model of care committees were abandoned and the therapists' guaranteed time for patient care support was also gutted after Kaiser had agreed to them as part of the 2022 strike settlement? Tell us what happened.
Thank you, Supervisor, for the question. I wish that I could give you a satisfying answer. I don't know why Kaiser has changed its attitude towards its employees. If they were here, maybe they would tell us, but they declined to come. But you heard just from the representative from the California Nurses Association that they have been taking an increasingly anti-union attitude toward their employees and the unions that their employees have chosen to represent them. As I mentioned in my testimony, we thought that the contract in Northern California in 2022 was a sign that things were going to improve, but it didn't last long. Very shortly after that, Kaiser changed the way it started to treat its employees. During this round of negotiations, as I said in my testimony, they have gone back on their commitment to fund the recommendations of the model of care committees. And I think that if you look at the model of care and the patient care support time issue, Kaiser's proposals are really just about squeezing more appointments into providers' schedules so that they can see more patients with fewer staff and reduce their need to subcontract. They recently told providers in the North Valley that they can only hire more staff if existing providers are more productive and discharge patients faster. So I think that the change in behavior that you're noticing and that we're seeing is really about Kaiser beginning to behave more and more like a for-profit type of entity and trying to squeeze employees more to maximize revenue.
Thank you. It's really clear to me. I think in this case, I think Kaiser is really using subcontracting and technology to paper over its care deficiencies, rather than spending times and ample resources to continue to recruit and retain enough therapists to meet patients' needs. Can you also elaborate on the extent to which Kaiser currently relies on staff therapists as opposed to subcontractors to provide behavioral health care, and also how the raw numbers and the ratio between them have shifted recently?
Yes. Since the 10-week strike in 2022 to establish our current contract, Kaiser enrollment in Northern California has increased slightly to 4.6 million enrollees, while the number of staff therapists has increased very slightly, if at all, despite Kaiser's acknowledgement as part of its settlement agreement with the state and federal government that it lacked the capacity to provide access to care consistent with the timely access requirements of the law. The most important fact is this. Since the pandemic, the need for behavioral health care has risen dramatically, especially among youth. In 2023, Kaiser CEO Greg Adams acknowledged that 20% more people came in for behavioral health care than at the same point the prior year. So what we're seeing is that enrollment is basically steady. The number of staff therapists is basically steady, but patient need for care has increased significantly. In order to meet this increased enrollee demand for care within the timeframes prescribed by law, Kaiser is outsourcing treatment to platform providers and substituting technology for human care. It's stretching its staff therapists to see more patients in the same amount of time. And it's also simply continuing to violate the requirements of the law and failing to meet the increase in its enrollees' needs. Hence the multiple and repeated settlement agreements and fines.
Okay, unfortunately, Kaiser's not here. Would be a question that I also would love to ask Kaiser. So you told me that, you have told us, not just myself, about Kaiser's demand for concessions. But what is NUHW proposing in negotiation, and what has been Kaiser's response to your proposals?
Thank you. You know, really, NUHW members are not proposing anything path-breaking. Our bargaining committee has proposed modest financial increases completely in line with what Kaiser has provided to the union employees of other unions, you know, in recent negotiations. As mentioned, we've proposed language regarding AI and technology that Kaiser has agreed to in other places, but is refusing to agree to in Northern California. I think there's one example that really underscores what we see as Kaiser's unreasonableness in these negotiations. NUHW clinicians have requested a mechanism to cap caseload for providers. And this is similar to the way that doctors at Kaiser have a cap. And what we've proposed would accomplish precisely what the Department of Labor settlement directed Kaiser to do, which is ensure that providers aren't given new patients when their schedules are so impacted that they can't provide their current patients the access that they need that meets the legal requirements for timely care. So in other words, NUHW members at the bargaining table have proposed a transparent and accountable process for accomplishing what Kaiser is required to do per the terms of its settlement agreement that it agreed to and signed with the Department of Labor. But Kaiser won't agree to that proposal and has not given us a counter proposal of their own. And so I think you look at all of this, what's happening at the bargaining table and what's been talked about here today, and it's clear that Kaiser has one standard for medical health care and a lesser standard for behavioral health care. Our members are trying to rebalance that, and Kaiser's refusing.
Thank you for your response. I would like to call up Tiana Liu, Clinician Liu. Ms. Liu, if Kaiser were to work in earnest with you and other staff therapists in establishing and implementing its model of care, what do you think the result would be?
I think patients would get much better care. I mean, the whole goal, right, is to have more clinicians providing care. So there would be a lot less pressure for us to graduate patients from treatments before they're even ready. And then we'll have more reasonable caseloads for clinicians for us, so then we can truly focus on providing that comprehensive treatment that that Kaiser so touts, right? And I think especially with therapy and treatment, it's really important to understand that it's not always a time-limited process, which is what Kaiser wants us to think, right? Kaiser wants folks to think. So some presentations require chronic care and treatment, and oftentimes patients come to us after waiting so long for care and are frustrated with us when we can only see them every 3 to 4 weeks at best, and then they give up on treatment and therapy altogether, so they just quit. We are completely letting down our communities, our patients, and people don't realize that clinicians at Kaiser are often in such, we are under such intense pressure to graduate outpatients when report has hardly even been built, and a lot of traumas and other things haven't even begun to be processed.
Thank you, and I think what you just shared, that it's really shortcutting clinical standards, and it's very concerning. What have you and your coworkers done to push back against these practices? And what does Kaiser say when you confront management? And what help have you gotten from professional bodies that establish generally accepted standards of care?
In terms of management support, in all honesty, I haven't gotten very much management support, and this is just my own opinion because I only work for San Francisco Kaiser. It may be different in other places, but it really feels like it's pushing against a brick wall. We're trying our best to get patients in within, allotted amount of care time, according to state law. But oftentimes we are, in a way, encouraged by management to, in a way, So when our clinical judgment as therapists dictates that a patient be seen sooner than we can actually see them again, the pressure from management is that it's to please revise our judgment and say it's appropriate to see them every 3 to 6 weeks so that the delay won't violate state law. So I would say that in terms of getting support from management, it is more of a pushback to follow their policies, their procedures, instead of our clinical practice, our ethics, and what we truly believe in.
And how you actually did that practice of pushing, like, because we have to follow the legality of like the months, and then you actually push a patient and say that you know it's okay to see the revisit again in a couple months later. That it's very concerning to me.
Yes, no, and I would say, you know, it definitely varies for me and my own experience and how I work with patients. That is something I definitely don't say. I try my best to fit them in as soon as I can, and in all honesty, transparency is key here, right? We're all working within a system that is hard to push back and change against. Yeah.
Thank you for your courage. Thank you.
Thank you.
My next set of questions is for Dr. Michaels. Dr. Michaels, based on the testimony we have heard from NUHW members, it seems like Kaiser is increasingly outsourcing clinical work to practice management companies, which most people call internet therapy platforms. What concerns should we have about how these companies are structured and how they manage the clinicians whom they use as independent contractors?
Mm-hmm. Well, thank you for that important question. These companies, these platforms are backed by 3 large and powerful groups. First, private equity and venture capital investors. Second, big tech companies, including Google and Amazon. And third, the major traditional insurance companies. Yes, they are directly involved and are major investors in these platforms. So this trio, they share a focus on profits, and they share a focus on pursuing growth and cost cutting. What they also share is that they don't necessarily know all that much about psychology or mental health care. They're very concerned and organized around how they can make money and make money for their investors, and they are not concerned or organized around what makes for quality care or the conditions needed for patients or therapists to provide that. Also, clinicians who are connected to these platforms are 1099 contractors. This is an Uber model. The platforms have a tremendous amount of control over the policies and things actually that rightly should be clinical decisions. So platforms are obtaining clinical data directly from patients without even asking or informing therapists. They're going around the therapist to get this data. They're also pressuring, for example, therapists in different ways to use their AI scribing and documentation tools. And they're collecting a massive amount of data, and this includes recording and retaining entire transcripts of therapy sessions. So yes, they want the data, which is extremely vulnerable and private. So they are on the path to training their own chatbots and also developing capitated payment models that will radically change the viability of mental health practice. So many, many concerns, and we documented a lot of this in our research report on these companies last year.
Thank you, Dr. Michael. And also my next question is, what elements of what Kaiser is proposing are different from what you have seen from other insurers? And what impact do you think they would have on industry-wide practices affecting patients' access to affordable, quality care and the ability of clinicians to provide its care ethically and sustainably?
Well, insurers are not proposing models of care, for one. They are not messing with the alliance directly, as Kaiser would be in their proposals. Traditional insurers are not mandating usages of AI. They are doing other things with AI. They're trying to create their own AI models and products. Aetna even announced a single-session AI product for 2027, which is extremely problematic. But they are not showing the same kinds of intent to with what Kaiser's wanting to do with substituting or using AI in those ways. But insurers do try to cut costs, similar to, I think, what Kaiser's doing. But they're not really inserting themselves into the definitions of treatment and directly overriding clinician autonomy in the ways that we've talked about and you've heard about today. I think all of these proposals from Kaiser would really add up to a drastically reduced access to care for patients. They're going to get less quality care, and these proposals will drive therapists out of the Kaiser network. So if patients want care within Kaiser, they're going to have to wait for it, and if they can't afford it, they will probably be likely to seek it outside of Kaiser and pay for it themselves. So I think it would be a very bad recipe for clinicians and for the public.
Thank you, Dr. Michaels. Board President, I don't have more questions if any of my colleagues would like to ask any.
They do. Supervisor Melgar.
Thank you, President. Thank you, Supervisor Chen, for calling these hearings and for your really good questions. I have been a Kaiser member since I was 18. All three of my daughters were born at Kaiser. I have gotten excellent care at Kaiser, not just through, pregnancies and childbirth, but also my husband, a while ago had a very serious health issue that got him to spend about a month at Kaiser and got nothing but excellent care from the very dedicated and professional staff there. And for all of these years, the one exception to that excellent care for my family was mental health related. When one of my daughters had an acute crisis, and what we accessed at Kaiser was not great. And left us having to seek other resources and what we were paying for, we had paid for decades. And so I take this issue very, very seriously, having lived through it and having been a loyal and dedicated Kaiser member, and for most of it, having received really excellent care provided by the staff. So I thank you again, Supervisor Chen, for calling this hearing. I recognize that there are some topics that are best discussed at the bargaining table or at mediation, but there's also a level of transparency that I think we need to have, given that this hearing is being held in public, because Kaiser is such an important part of the network of care in San Francisco. And also, Kaiser provides health care for a big part of the employees of the city and county of San Francisco, myself included, and our dependents. So I want to make sure that Kaiser, with our contributions, are putting patients' interests first, and connecting patients with what they need, and not putting that sort of second. It is an issue of public interest. I am really disappointed that they're not here. The last time I met with Kaiser leadership was in my role as a land use and transportation committee chair, because they're seeking an expansion of their campus, which I support, and the city, in County of San Francisco will negotiate with them, but, they're coming to us asking for something, and I think that it is fair to be transparent about what is going on. So I hope they're listening today. I am disappointed that they're not here. And I think that they might have tried a different approach in their relationship with us. But to that end, I will, direct some of my questions to Alana, who spoke earlier. Alana, you're still here? There we are. So, You talked a little bit about what happened when AI tools were first deployed during your work. So I'm hoping that you can talk us through like what happened, when this was rolled out. What was your response? Not just at the bargaining table, but like what was your response like with your coworkers when you were told this is what's going on now? Like, what did that look like with your supervisors?
Sure. As soon as we found out that Kaiser had unlicensed clerical staff doing triage work, which was kind of the beginning of this erosion of triage, we filed a grievance, which over 2 years later hasn't been scheduled for arbitration. We also filed a charge with the NLRB, National Labor Relations Board, which they have since deferred back to the grievance and arbitration process. And we filed a complaint with the DMHC alleging violations of California law, which limits triage to qualified licensed individuals, and the DMHC reports to us that they are still investigating. But interpersonally, we were very alarmed, right? Because I, shared your experience as having phenomenal care. I've had 2 babies at Kaiser. I'm a lifetime member. And as an employee in psychiatry, I have seen a much darker side of Kaiser than I ever saw as a patient prior. So my colleagues and I were alarmed, right? I mean, I have been trained. It took me a decade and a half through experience, practice, going through all the state requirements, and I was told when I was going through that by the state, you will, you have to go through this because public safety is in your hands. So my colleagues and I all together, essentially, we've worked our entire careers to access doing clinical triage and to quickly learn that operators and algorithms can just quickly do what has taken me many, many years of experience, and my colleagues. We were all very, very frustrated.
So, Alana, what happens to the patient? So if they are triaged by someone, someone who's not licensed or someone who's not even a person, what happens if then they're assigned to something that's not appropriate or that they feel is not helping them or that doesn't meet their needs? Then what is their recourse?
Right. So to answer bluntly, we don't always know what happens to those patients when the bots and operators get it wrong, especially when they're outsourced because they're now outside of the integrative health plan. So I only really know of the patients who either a provider or themselves are strong self-advocates. So when patients advocate for themselves or the external program determines that they're not appropriate for their program, they end up booked with me. And instead of talking to me a month ago, we're talking down the road when the patient is frustrated, likely deteriorated. A lot of the evidence suggests that the beginning of one's care episode is the opportunity to instill hope. And when we can't instill that hope in the beginning, a lot of people give up. So when they make it to me after great delays, I actually conduct a thorough assessment to correct their treatment plan and connect them to the clinically appropriate care. Oftentimes patients are confused, upset, and they often get angry that they got misdirected in the first place. As I said earlier, apologizing has become a routine part of my day. So, I'm doing what I call service recovery as opposed to the original triage and clinical assessment job that I signed up for many years ago. Bottom line, patients that are already suffering from their psychiatric impairment are suffering even further from the delays in care that the unlicensed operator or algorithmic-based triage creates, and those consequences are unfortunately quite dire.
Thank you. That's my questions. Thank you.
Supervisor Fielder.
Thank you, President Middleman. Thank you, Supervisor Chen, for calling for this hearing. Thank you to everyone who's shown up today. I have a question for Dr. Michaels. Dr. Michaels, at the end of your testimony, you predicted a set of negative results for clinicians, patients, and Kaiser itself if Kaiser management were to succeed in forcing its terrible 3 contract demands on NUHW members. Could you expand on how you inferred those specific results from the specific content of what Kaiser management is asking NUHW members to accept?
Sure, thank you. I mean, it's not too vague of an inference. These things have been tried in other settings, and there's evidence to show that these are the results. This is what happens. So, for example, if we think about for patients, if there is a one-size-fits-all or a standardized model, which is one of the things that Kaiser wants to do, we know that that's not going to work for everybody. Different people need different treatment approaches, which is why we have different models, and therapists are trained in multiple models and also use the information they obtain from their work with each individual patient to adapt, even within a session, as well as over time. So we know that when somebody receives treatment that is not the right model or the right approach for them, they don't feel good. They don't feel helped. They don't feel understood. They think therapy doesn't work, or therapy doesn't work for me. Maybe I'm not able to be helped. Their symptoms may worsen. They may drop out of treatment altogether. Dropouts will also probably increase from the outsourcing situation when patients are shuttled to different therapists, or they have to interact with an AI. This is a direct interruption of the alliance. And so the alliance is the reason and the method by which therapy works, and when you're interrupting that alliance and messing with it, results are going to decrease. Outcomes will worsen. And then finally, when there is a lack of autonomy for the therapist and more burnout, more time pressures, et cetera, and there's more turnover of therapists, then patients are also likely to drop out of care. When their therapist leaves, they'll probably leave as well. So adding all of this up together for the patients, I think outcomes will worsen. People will suffer more, and it's unnecessary. There's also, for the clinicians, as some people have said, we are duty-bound by our code of ethics. Each degree or discipline has a specific code of ethics, and we have a state license, and we are accountable to providing care according to those ethical standards and the terms of our license. If something goes wrong, it's on us. And in some of these changes that Kaiser is proposing, that accountability and responsibility would be diffused and taken away. And the AI doesn't have a license. It didn't go to graduate school. This is not a very good plan at all for quality care. And I think, while a lot of these policies may save Kaiser money in the short term, which I imagine that is their main motivation for proposing these things, they will actually create new and higher costs in the long term, in terms of replacing therapists, in terms of medical costs for patients who don't get appropriate care. It's a very costly long-term gambit that Kaiser is playing here, and it's not good for patients, for therapists, or really even for Kaiser itself.
Thank you, Supervisor Fielder. Supervisor Walton was observing to me earlier that this hearing really would have been a more useful exercise for the members of the Board of Supervisors if Kaiser had deigned to send representation. And I can certainly understand them not wanting to be here to hear this story and respond to our questions. On the other hand, their non-presence, suggests to me that the story is basically right, and that the picture that's being painted by the workers is pretty accurate of a large business that is interested in squeezing efficiencies out of an under-resourced part of its operation, with bad consequences that are a concern to this Board of Supervisors. Supervisor Melgar, as you indicated, I mean, we are concerned about how workers get treated in our city. We are concerned about how folks who live in San Francisco and who are members of Kaiser and have mental health needs are treated and get care or do not get care. But we are also a purchaser. We have, many, many, many San Francisco city employees who either themselves or their families at some point are going to need behavioral health resources, and we do not want to be subjecting our employees to and our retirees to a situation where they can't actually get the care that they need. The picture we've heard is pretty dystopian. I mean, it's sort of your imagination of the worst call center, except you're not arguing about, with this bot about, some product, the shoes. You're arguing with the bot about the kind of care that you're going to get for your kid, and that's, not good. I guess I guess I would like to invite Ms. Marcucci Morris to come back. You're in high demand. I mean, it would be interesting, again, if Kaiser were here.
Sure.
We could have a conversation about how might AI, what are you trying to do with AI? And the ways in which, it sounds entirely believable that they're, trying to turn over this kind of intake work to a process that does not involve people. And that seems really wrong and I guess illegal in this context. But I mean, I don't think that as I understand it, the clinicians at Kaiser are not saying no AI never. You're saying AI yes, but use it to make us better as clinicians, I think. But can you talk a little bit more about how AI could be deployed responsibly in ways that would support therapists' work rather than replacing it inappropriately, and how could AI help address the staffing shortage?
Sure. There's a long history of, technology and innovation really helping the medical field. So I myself, and as a union, we are not anti-AI. We are not anti-innovation. I know that I sound skeptical about the use of AI, but that's because I care deeply about patient privacy and care effectiveness. As Dr. Michaels shared, you start recording sessions, you enter a third party into the room, the nature of that alliance is severed. There's just no data that supports it. So I want to see that data first before making massive public health decisions. But I've seen how Kaiser has time and time again made changes in our daily operations in the name of improving access or patient care when the changes are more about their bottom line. So as a union, we're not against the responsible use of AI, using AI that supports therapists, protects patient privacy, and does not remove humans from this human work of therapy. I can see AI used to remove some menial tasks, address operational inefficiencies like paperwork or administrative lag. We're seeing the same problems in those realms that we did a decade ago. So I'd like to see it used there, or maybe even in ways that would help us hone our skills as human therapists. But before AI is deployed at any matter, it is absolutely necessary that the therapists who will be using or affected by AI tools have a real voice in how it's deployed. I fear that the tech industry, alongside my employer, simply sees a profit-making opportunity, including the cost savings of laying off human providers, and is not genuinely motivated by improving access, innovation, or overall care experiences. And you mentioned the shortage. So very respectfully, we push back on the true existence of a therapist shortage, especially in San Francisco. I cannot throw a rock on Market Street without hitting 5 MFTs. The shortage is not...
Please don't.
I will not. Scouts on, I promise. Do no harm, am I right? The shortage is not available therapists, supervisors. The shortage are therapists that can make a living on the pay rates unilaterally determined by the health plans. The shortage are providers taking insurance or willing to accept factory assembly line working conditions that now want to push questionable technology on us as well. That's the shortage here. There are plenty of us willing to work and support human healing when given the appropriate resources to do so according to industry standards of care. Just from a mental exercise perspective, if there is a human shortage, help me understand why laying off the humans committed to the work is the viable solution. I quote my colleague, make it make sense. So. That's how I feel about that.
Thank you for that. It is, if our Kaiser representatives were here,
I would love it.
I would ask them, why this language that seems pretty reasonable and has worked its way into another contract, would not work in Northern California. But of course, we cannot ask that question, or at least we can ask it, but it's going into the void. All right, thank you.
Thank you so much.
Yeah. And then I do have a couple of questions for Ms. Parsons. Welcome back.
Hello, thank you.
Hello. So you're in an interesting spot in that you're both inside and outside. You are both a Kaiser therapist, and you've worked or currently work as an independent provider?
Correct.
Okay.
But I do not see Kaiser clients through that.
Okay.
We're not allowed to.
Okay.
Everyone heard that, right?
So I'm wondering, given that, if you could talk a little bit more about the differences and the problems that you face working as a Kaiser staff therapist and the problems that you face when working as an independent provider, and tell us what you think are the best and worst parts of the work on both sides of that divide.
Yeah, so I already named, right, that the integrated care model that Kaiser says it has, when it actually works, it works very well, right? So as a Kaiser staff therapist, I can see what's going on with my clients, right? Perfect example is I had a woman who was 41 weeks pregnant, and she was terrified of getting an induction, and I could just look in her chart to see, has she given birth yet? Is she in there? What's going on? What's happening, right? And in any opening I had, I actually scheduled her to call her because she was terrified. And I actually, same as some of us here, right, have been through that. I've given birth at Kaiser. I was induced 2 times. So I can use that personal experience to say, like, hey, this is what you might be able to expect. Let's talk about your anxiety. Let's talk about your worry. I cannot do that when I work as a third-party contractor because I don't have any other notes than my own, right? There's no information. There's no test results. There's no doctors that I can just message and say, hey, what's going on? Hey, this is a concern they have, right? This particular client, I messaged her OB and said, this is a big concern she has. Just want to give you a heads up, right? So that's probably the downfall of working with a third-party contractor. In terms of Kaiser, the biggest challenge is time, right? I mean, we've all talked about it. But in our contract right now, every single return patient we have, meaning we've seen them before and they are returning to us those slots, right? For every 5 of those we see, we have 1 intake, meaning we've not seen this person before, or at least not in the last year. And so the expectation is if I'm getting 5 new clients a week, let's say, right? Let's say I see 30 patients and 5 of them are new. To make that all fit, I have to be terminating or closing services with 5 return patients, which is just not happening, of course, right? Especially because we don't really get to see return patients as much as we should. So if I see a return patient once every 4 to 6 weeks, it's obviously going to take longer for them to recover if I could see them weekly. There are also certain models of care where really ethically I should be seeing them weekly. You know, EMDR, for example, is a service we offer. You need to see someone weekly for that. But they're not booked weekly because there's just not time for that. Another issue I see within Kaiser is I'm a specialist. So I do couples therapy. I'm a certified sex therapist. I'm a perinatal mental health specialist. Those are all things that people really want, right? I'm one of 3 sex therapists within the entire Northern California region, right? And I can put that on my profile in terms of third-party contractor, right? They can go, they can see like, oh, she does this, she does that, that's great, I want to book with her. Within Kaiser, I have worked there for 5 years. About 1 year ago, so 4 years in, I found out that therapists could create their own My Doctor Online profile, which if you've had a PCP, if you've been with Kaiser, you can go and look at the doctors and they say information about them. I didn't know we could do that in mental health. So about a year ago, I filled one out. And then I started getting referrals for certified sex therapists. And my manager, who wanted that service, my manager told me to take that off my profile because my schedule was getting too full with people outside of my service area. I refused. I kept it on there because legally speaking, you can be seen anywhere within the Northern California region as a Kaiser patient. But that's another problem, right? Even if you have an issue within Kaiser, you're not directed to that specialist. And this has become more of an issue since Triage left, right? Since we've had robots and people I don't even know, scheduling into our appointment slots. Because, if like I'm trying not to use the terminology in the shortcuts. If an intake assessment coordinator who works in my office says, oh, this patient is, has postpartum depression, he's going to reach out to me or book them in my schedule, right? A robot certainly can't do that, So that's another big issue within working with Kaiser, is that clients don't always get the specialized care they need.
So notwithstanding those challenges, it seems like it would be good to bring more care back in-house. And I'm wondering if you have thoughts on things that Kaiser could do to do that and what benefits that would have for the current workforce and for Kaiser enrollees.
Right. So, you heard that Kaiser's, amount of enrollees has been about the same. The amount of therapists has been about the same, but the enrollees wanting mental health care has gone up by 20%, which is significant. That's a huge jump. So obviously it makes sense to have more clinicians, right? That's the obvious answer. And giving us caseload caps, which also makes sense. Again, I can't be intaking patients if I have no open slots, and I can't be seeing my patients as much as they need what is actually ethical if I have no slots. So keeping a full staff of therapists, right? Psychiatrists, case managers, assessment intake coordinators, intensive outpatient program clinicians, right? And it does mean hiring more clinicians. But instead, Kaiser is paying to outsource care to clinicians who work for third-party contractors who do have caseload caps, right? Those third-party contractors, we see it all the time, like, oh, we need to refer to the external provider network, which is a whole list of people. And sometimes those certain, like Grow or Rule or whatever, there are no open slots to refer to because their clinicians have caseload caps. And if there are no clinicians who have openings, that is not a resource that we can send to, so we have to look for a different one.
All right. Thank you.
Yeah, thank you very much.
If other colleagues have questions, there we go. Supervisor Chen.
Thank you, President Mandelman. Thank you, Supervisor Chen, for today's hearing. I do not have additional questions. I think what I would like to see is if we're at the end of this hearing is that since we're holding this hearing as a committee of the whole, is that perhaps we could either subpoena Kaiser or that we issue a letter on behalf of the Board of Supervisors to Kaiser indicating all the questions that we had today collectively as a committee of the whole and be able to subpoena Kaiser for the answer to our questions. Thank you.
Thank you, Supervisor Chen. Supervisor Chen, do you have any comments before we go to public comment?
No, I do. Let's go to public comment first, then I'm going to offer closing remarks.
Public comment, right?
If you would like to provide public comment on item 52, please line up to speak now on the right-hand side of the chamber. Once we exhaust the in-person line, we will go to our remote callers. If you anticipate providing remote public comment, the telephone number and meeting ID are published on the agenda and streaming on your screen. First public commenter here in person.
Excuse me. My name is Barry Toronto, and I am a Kaiser patient. I want to speak first because I have a Kaiser class online in 10 minutes. So, and it has to relate to this subject matter. They offer great classes. And also, they did a great job on my cataracts for my eyes. The only thing I don't understand is why they don't care about doing a great job on mental health counseling. That doesn't make sense to me, how you provide all these great services, but you don't want to continue it. I mean, AI, if you watch 2.5 Men and Charlie Sheen and the Therapist, you got to have a therapist, the back and forth. AI doesn't have the graduate degree, which is true. It doesn't make sense to do it this way when all logic goes the other way. So Kaiser has great employees, and not only that, but they're not here for their pay; they're here for their patients. So it shows Kaiser should be happy and be here to see all the support for Kaiser patients. But obviously, it's about Kaiser trying to save money rather than care about their patients' health. So I'm very much concerned. So caring about fellow union brothers and sisters, I think it's important that we get answers from Kaiser and ask them to join the crowd and the community to care about the mental health of the city and especially their patients. Thank you very much.
Thank you, Mr. Toronto, for your comments. Next speaker.
Hi, Supervisors. Ian Lewis, Unite Here, the Hotel and Restaurant Workers Union. Among our members, we have fought for and won healthcare benefits for 65,000 Kaiser patients around this country, including 14,000 here in San Francisco. And, it's especially that people choose Kaiser because of the promise of Kaiser, the promise of integrated, coordinated, human-based care. That's especially important to a community like ours, where 3/4 are born overseas, grow up speaking different languages. Incredibly important to navigate a health system. And they choose Kaiser despite the price. You all know how hard our union has fought for health care, especially in this city. The U.S. spends twice as much as any other country on health care. Northern California spends twice that. Our health benefits for a family cost $18.40 at Kaiser. That comes out of our members' pockets here in San Francisco. That's almost 5 times the minimum spending requirement in San Francisco for health care. It's almost not quite the minimum wage in San Francisco. And I bring that up because it's not for a lack of resources that all of this is happening. It's because of concerted choices. And I know the fact that Kaiser undervalues behavioral health compared to other healthcare is not a surprise to anybody here, but what you've heard today should terrify you as leaders of a city which is the biggest purchaser of healthcare benefits and leaders of a county that is entrusted with the public health. It sounds to me like Kaiser is leading us down the track of a K-shaped economy in healthcare, where for working people, even those who can give up $18 an hour for excellent healthcare benefits, we are offered inhuman technology and precarious gig workers. And the only people who are going to be left with true human-based care are those who can pay out of cash out of their pockets. No political community can.
Apologies for cutting you off. We are providing everybody the same 2 minutes. Next speaker.
Kim Cavalloni, San Francisco Labor Council. We live in very strange times, and all of you should be very concerned about the health and welfare of our city employees. We've already had a tragedy happen down in VTA in San Jose. The mental health of our city employees is critical to them being able to do their jobs day in and day out. The fact that Kaiser wants to lead with the same AI that can't distinguish a cone from a dog to a person on the street and put that in charge of mental health care, you should all be like terrified of what can happen to our workers and what happens in our city and county. We know AI is imperfect, but we cannot allow Kaiser to experiment on our city and county workers. We know it doesn't work. We know AI doesn't value life. It can't. It's not alive. But allowing our city and county workers to receive this type of care is completely unacceptable on so many levels. AI can't value life. It doesn't distinguish whether the cone has a life, a dog has a life, or a person has a life. And them taking it away means nothing to the machine other than someone has to tell it that it was wrong. Thank you.
Thank you for your comments. Let's have the next speaker, please.
Good afternoon. My name is Bindu Mukamla. I serve as the policy manager for the National Association of Social Workers, California chapter. In response to Kaiser Permanente's Terrible 3 proposals, we asked our social work members, comprised of Kaiser patients and employees, how these changes are affecting care. And the feedback we received was consistent. These proposals shift the focus away from clinical decision-making towards reducing costs. One major concern was the proposal to have behavioral health triage conducted by call center staff or non-licensed personnel instead of licensed behavioral health providers. As one of our social workers shared, quote, "If we want better triage, Kaiser needs a formal intake department, not a call center," end quote. Another shared that even when they identify a patient is in urgent need of therapy, they must still send that patient through a phone triage process with an unlicensed representative before connecting them with care. And of those we contacted, 95% reported being not at all confident that Kaiser's cell phone service representatives are consistently meeting California's requirements that limit non-licensed staff from making clinical assessments on determining when patients need licensed behavioral health care. Providers also raised concern about the loss of continuity of care. Patients are being redirected to outside providers to meet those access metrics, even when they have an established therapeutic relationship. One provider described patients being referred to, quote, "a brand new provider instead of booking a sooner appointment with their regular provider made to start all over again." So taken together, these concerns reflect a need to prioritize clinical expertise, continuity of care, and patient safety over administrative efficiency. We urge Kaiser Permanente to listen to the concerns of patients and providers. Thank you for your time.
Thank you for your comments. Let's have the next speaker, please.
Hello, good afternoon. My name is Dr. Guillermo Rodriguez, and I'm the Region B Director for NASW California chapter. It's a pleasure to be here. I'm here to advocate for all the social workers, for the team here, for the voices who are here today advocating. Usually policies get implemented when something tragic happens. Let's not get to that point. We want to implement policies to stop any tragedies of mental health. On Kaiser's website, it states, quote, "We believe a person's physical health, mental health, and social health are all connected and essential to a person's overall well-being." End quote. As social workers, we agree with that, but those words must be reflected into practice. With Kaiser not being here, it speaks volumes. It hurts a little bit, or a lot for some of us, but I wish they could be here so I could hear what they have to say in regards to the voices in today's room. Thank you so much.
Thank you for your comments. Next speaker, please. And as this speaker approaches the microphone, if we have anyone else in the room who has public comment for this committee of the whole hearing from whom we have not yet heard, you may line up to speak along that western wall. Next speaker, please.
Good evening. This has been an extremely interesting presentation, and I certainly think it's important to keep the humanity in medicine and in other activities, certainly in therapy. There were many issues raised about quality, privacy, accountability, who controls the AI, who controls changes that might be made. There's no such thing as a fixed item. There are apparently many differences in how AI is working. Who's responsible for making supposed improvements or providing so-called guardrails, which we've heard and read about failing quite a lot. The New York Times had an extended story about a couple whose son, teenage son, was helped by a chat pal, as it were, basically to work out all the details of how to commit suicide. And as the very last step, the son, for now a second time, said, I'm thinking of, and the Times got the exchanges between their son and the chat. He said, I'm thinking of leaving the rope lying around so somebody will find it. And the chat answered, and I'm paraphrasing, not such a good idea. Maybe you should let the folks learn what you've planned when you have succeeded, basically when they find you in the closet hanging from the bar with a rope that the chat helped the kid make. So the AI is working with a whole different world of who knows what motives and purposes, making money for the company that made it and so on. Big problem. Thank you.
Thank you for your comments. Seeing no other individuals who are in person, we will go to our remote call-in line. If you have not already done so, please press *3 to line up remotely. When it's your turn to speak, listen carefully, and when the system says you have been unmuted, that is your cue to begin your comments. Let's hear from our first caller. Welcome, speaker. That concludes the comment queue, Mr. President.
And that message was brought to you by your California State Legislature. Which is not subject to the requirements of remote public comment. Public comment is now closed. Supervisor Chen, this is your hearing.
Thank you, Board President Mandelman. I would like to take a moment to thank everyone who attended today's hearing. I especially want to appreciate the workers. Thank you. Thank you for taking time off to educate us on everything that you are going on at your workplace. Your commitment to patient care quality, patient safety, is loud and very clear. The things that we discussed today are infuriating, concerning, and unacceptable. It is a shame that Kaiser didn't send a representative to answer our questions, or at least to listen to testimony provided today. Next Tuesday, I will be introducing a resolution calling on Kaiser to drop its terrible 3E contract demands, as outlined by the testimony and presentation we heard today. With that, I want to shout out to my legislative aide, Jackie Prager, for her work on this hearing, and also the resolution that I will be introducing next Tuesday. Through the chair, I would like to make a motion to file this hearing.
All right. I think I just gavel that, right? Okay. This matter has been heard and is now filed.